I'd like to thank you all for the opportunity to present today. When I find which one of these advances the slides. Aha. Okay. So the views in this presentation are mine, and the only disclosure I have is that I'm going to try my best to talk about all of the research that people are doing around here about REBOA, but I only have 50 minutes, so I'm sure I'm going to leave some people out. I want to explain the origin of REBOA and the REBOA catheter, discuss the application of REBOA around the world, highlight the contributions our program has made to shaping these practices, and describe our ongoing research efforts. So we'll begin with the origins of REBOA. What is it and where did it come from? REBOA stands for Resuscitative Endovascular Balloon Occlusion of the Aorta, which by now is familiar to the audience. The idea of intra-aortic balloon occlusion is not new, however. It was first described by Colonel Hughes for use in 6 wounded soldiers during the Korean War. Unfortunately, none of these patients survived, and the idea died out until endovascular technology could catch up to his vision. By the mid-2000s, endovascular technology had advanced to the point of broad adoption. Its first major application of aortic balloon occlusion was for the management of ruptured aortic aneurysms. And during this time period, the popularity of endovascular approaches to vascular surgery grew until it began to overtake open surgery for many conditions, including aortic and iliac artery aneurysm repair. By 2010, in the midst of war in the Middle East, the Air Force was deploying vascular surgeons with significant endovascular experience to war as trauma surgeons. These surgeons were struck by the number of soldiers who died by surgically treatable diseases because they couldn't reach the operating room in time. An adjunctive measure was required in order to stem non-compressible torso hemorrhage until these patients arrived at definitive care. It was then that Drs. John Eliason and Todd Rasmussen described the potential use of endovascular aortic occlusion balloons for the management of trauma and coined the term REBOA. In this landmark publication, they also defined the zones of aortic occlusion to create common terminology and to discuss the associated physiologic impact of occlusion in these locations. However, the predominant balloon being used for REBOA at the time was the COTA catheter. It was long and cumbersome with wires and image guidance for placement. It could only pass through a 12-French sheath, so multiple dilators were required for safe insertion. The sheath was so large that it risked obturating flow to the access extremity, and removal required open surgical repair. So some serious complications were being reported. For REBOA to be adopted more broadly, a user-friendly catheter suited to military and civilian applications was required. Easier, faster, and safer placement without image guidance was desired to suit the potentially austere environments that were encountered close to the point of injury. They took these lessons to heart and designed the Eliason-Rasmussen REBOA catheter, which has become the predominant aortic occlusion balloon used for trauma across the country. It passes through a low-profile 7-French sheath, has a nitinol stiffened catheter that can be inserted without a guide wire, has centimeter markings along its length to facilitate fluoroscopy-free positioning, and an atraumatic tip to minimize the risk of migration into branch vessels. It has a compliant balloon that adjusts to accommodate aortas of various sizes up to 32 millimeters, and an inline arterial pressure monitor for continuous proximal blood pressure measurements. UC Davis was an early adopter of this new technology, and we were the first to report using the ER REBOA catheter in a clinical scenario. Our success garnered attention around the world and across many disciplines. The advantages of this new device led to its rapid adoption at high-volume trauma centers across the U.S. The adoption of the ER REBOA catheter was associated with fewer complications than the larger COTA balloon, and it is now the predominant REBOA catheter in the country. Our experience here parallels the international experience as hospitals around the world shift to adopt 7 French catheters. While indications for REBOA are still hotly debated, we'll now talk about some ways in which it is being used. REBOA has 3 major applications that stem from the physiologic changes induced by aortic occlusion. It increases blood flow to the heart and brain, stops hemorrhage distal to the level of occlusion, and decreases the volume of distribution of circulating blood, thus shunting remaining blood to proximal organs and reducing the need for resuscitative fluids. The American Association for the Surgery on Trauma's Multi-Institutional Trials Committee developed the aortic occlusion for the Resuscitation in Trauma and Acute Care Surgery, or aorta registry, led by Dr. DeBose, to figure out early practice patterns of how these physiologic changes were being implemented with REBOA around the country. The first manuscript on the early practice patterns was published by Dr. DeBose in 2016 when he was here at UC Davis. At that time, 46 REBOA deployments were captured in the database from 5 hospitals that were using REBOA, all of which were level 1 trauma centers, and all of the uses were for traumatic hemorrhage. The institutions that were performing REBOA at the time of the initial aorta trial all reported using the 12 to 14 French REBOA catheters, placed most commonly by open cut-down. The predominant use of REBOA was as an alternative method of resuscitative thoracotomy in patients dying from internal abdominal and pelvic hemorrhage. Survival was equivalent between open aortic cross-clamping and REBOA, which in this study was 20%. Relative to the time of presentation to the hospital and for the onset of hypotension, REBOA was being used rather late in the patient's course of care. Around the same time, the Basic Endovascular Skills for Trauma course was developed by the American College of Surgeons to teach surgeons how to use REBOA. UC Davis became one of only 3 institutions offering this training and has since trained hundreds of doctors across the country. The REBOA simulator being used in this course was based on a model built right here by Ben Keller and colleagues. And in the 2 years since the development of this easier-to-use technology, increasing education and increasing press, REBOA has been rapidly expanding. Since the release of the ER REBOA catheter and this first publication from the aorta registry, the number of REBOA-equipped hospitals has increased from 5 to 244. Of about half are now level 1 trauma centers, and how this has affected its use and outcomes is not yet known. Some newer algorithms may give us insight as to how REBOA might be used. While the initial algorithms focused on REBOA as a minimally invasive alternative to resuscitative thoracotomy, these newer algorithms emphasize that REBOA is a tool with completely different indications. This recently published algorithm by Dr. Holcomb's group features REBOA both as a hemorrhage control device and as a resuscitation device. This paradigm shift is seen in their recommendation to consider REBOA for patients who are in extremis, even in the absence of internal hemorrhage. This makes reference to experience by Dr. Moore's group in Denver, who's reported several cases of patients who have arrived in extremis from nearly exsanguinating from a non-junctional extremity injury. They survived after being managed with an extremity tourniquet in combination with REBOA as an adjunct to blood transfusion. Of course, the Stop the Bleed campaign aims to try to prevent these situations from occurring through the application of early tourniquet use. But REBOA nonetheless can be considered to salvage a patient who arrives in the ED almost about to code. And REBOA may still be useful after traumatic arrest. Dr. Holcomb's paper makes reference to the literature demonstrating that patients who are under CPR have a faster return of spontaneous circulation with REBOA and closed chest compressions than with open cardiac massage and aortic cross-clamping. This has some hospitals revising their algorithm as to when to initiate attempts to salvage patients who have experienced traumatic arrest. But the most important takeaway here is the idea that unstable patients should have femoral arterial access to serve as potential REBOA access, to provide continuous pressure monitoring, and to be an additional route for fluid administration. This change in ideology underscores the growing ways in which REBOA is being used outside of trauma and vascular surgery. Expanding indications include other forms of non-compressible hemorrhage, most commonly GI bleeding. Experience is building around the world with hybrid approaches to hemorrhage control in patients with variceal and non-variceal GI bleeding. REBOA can serve as an adjunct to interventional or open surgical hemostasis. And UC Davis has begun to consider the utility of REBOA in these situations, with at least one use for patients with severe bleeding from hemorrhagic pancreatitis. Obstetric hemorrhage is another rapidly growing indication for potential REBOA application. At our own institution, we used REBOA as an adjunct to the complex cesarean hysterectomy performed for a young Jehovah's Witness woman with placenta previa percreta that was invading into her bladder, who presented with preterm premature rupture of the membranes at 24 weeks gestation. The multidisciplinary team approach to this patient's care ensured the survival of the mother and infant against all odds, despite an 80% predicted mortality. The publication of our experience has garnered worldwide attention and led to the incorporation of REBOA into the algorithms of difficult deliveries for obstetric departments across the country. As many as 8 similar uses have been reported since our first experience was published last year, with another couple of lives saved by REBOA for complex abnormal placentation just 2 weeks ago. For this reason, there are now being newer versions of the REBOA catheter developed specifically for obstetric use. The prophylactic placement of REBOA access or even balloon prepositioning has been suggested for high-risk elective cases in which there is risk of major hemorrhage or sudden uncontrolled blood loss. Surgical oncology, orthopedic surgery, and liver transplantation are a few of the fields that have described the use of REBOA as an adjunct to reduce blood loss during planned high-risk operations. The ability of REBOA to increase coronary blood flow has also led to its investigation in non-traumatic cardiac arrest. Substantial research has gone into evaluating the role of REBOA as an adjunct to advanced cardiac life support. These EKGs are in a UC Davis patient that received REBOA during an active MI. Normalization of the ST depressions was readily seen after balloon inflation. The patient was stabilized and the balloon was able to be deflated. The femoral access could then be used for percutaneous cardiac intervention. Following our experience with that patient, UC Davis formed a partnership and launched an initiative with Yale to investigate REBOA as an adjunct to cardiac arrest. The preliminary plans were presented at the Pan American Endovascular Trauma and Resuscitation Management Conference in February during the session on REBOA for cardiac arrest. I just wanted to take this time to point out a couple of issues that I noticed with it though. It was called the Yale and UC Davis Initiative and was presented by someone from Yale. The PI on this project is from UC Davis, so I think we may have missed an opportunity here. As it was envisioned by Dr. Eliasson and Rasmussen, REBOA is also making inroads as a transportation device to bridge the gap between injury and definitive care. Most of the American experience with REBOA as a transport device has come from the forward deployed setting. As we've heard from Eric's grand rounds about prolonged field care, he's working with our military partners to improve the utility of REBOA as part of the medical care for special operations deployments. Last year, the ER REBOA catheter was placed for the first time outside a hospital by a Special Forces surgeon. In a small concrete house operating with the tools from his rucksack, he placed REBOA in 4 seriously injured patients with a 100% survival rate. Internationally, physician-led pre-hospital response teams have also been successful at deploying REBOA in a pre-hospital setting. And while there is much interest using REBOA for transport within the U.S., and some have tried to send patients here with REBOAs in place, this practice is not advisable domestically. The role of REBOA as an inflow occlusion device for major venous hemorrhage is also being investigated. Even deploying REBOAs within the vena cava for total hepatic occlusion is being theorized. So if 1 REBOA is good, 3 could be better. REBOA is also being investigated for the pediatric population. UC Davis surgeons DeSoucy, Stevenson, and Trappe have taken an interest in this application. As indications for REBOA expand, contraindications to REBOA are also being debated. When considering the risks of REBOA, it's important to consider the physiologic consequences again. Looked at a different way, by increasing blood flow to the heart, lungs, and brain, it may create dangerously high blood pressure that leads to heart failure, respiratory failure, or worsening brain injury. The longer the balloon stays inflated, the more ischemia develops in distal tissue beds. And the sudden loss of aortic afterload following balloon deflation, together with the return of ischemic metabolites, leads to hemodynamic instability that may cause vascular collapse. This graph depicts hemodynamic effects of zone 1 supraceliac aortic occlusion on proximal mean arterial blood pressure during various degrees of hemorrhagic shock. In early shock, when only 10 to 20% of the blood volume has been lost, aortic occlusion can create dangerous hypertension with mean arterial pressure as high as 140 millimeters of mercury. So it's important when considering the prophylactic use for elective surgeries and understanding that the anesthesiologist should anticipate spikes in proximal blood pressure and be prepared with vasodilators in order to maintain normotension. In grade 3 shock, with 30% hemorrhage, REBOA inflation means normotension without additional resuscitation. But with more profound grade 4 hemorrhage, REBOA can maintain MAP sufficient for cerebral perfusion. However, to get the balloon down, more resuscitation is required after definitive hemorrhage control. The variable hemodynamic effect of REBOA that changes based on the patient's degree of hemorrhage and degree of resuscitation is a key concept that we'll come back to again and again. Traditional contraindications to REBOA include injuries proximal to the point of occlusion. Typically, thoracic trauma is a contraindication to REBOA due to concerns that distal occlusion will exacerbate proximal hemorrhage. However, the spectrum of injuries constituting thoracic trauma varies widely. Therefore, many believe that REBOA can be used in the setting of combined thoraco-abdominal trauma when there is no major thoracic vessel injury. As such, the effect of REBOA on pulmonary contusion, ARDS, in survivors is being investigated in the lab by Carl Byers. Although most would consider intrathoracic large vessel injury a contraindication to REBOA, some have challenged this notion. Proponents advocate that REBOA can control abdominal hemorrhage and afford temporary stability to allow concurrent repair of injuries in the chest. But this approach is only feasible when access to the operating room is readily available. Brain injury is an area of research that's of particular focus here at the lab of David Grant and the lab that I'm joining with Dr. Alam in Michigan. Our previous investigations demonstrated that REBOA increased carotid blood flow and intracranial pressure proportionally. This finding challenged previously held beliefs about cerebral autoregulation and suggested that REBOA may worsen traumatic brain injury. So we then performed an experiment to examine the effects of the hemodynamic changes on brain injury. Early on, it seemed clear that REBOA worsened TBI. However, alternative explanations were possible. Going back to our hemodynamic study examining the impact of REBOA on proximal MAP, we used a 25% hemorrhage model for the TBI experiment, which meant that the animals receiving REBOA had MAPs near 100 throughout the occlusion period and became hypotensive after balloon deflation. So could it be what we were really seeing was the effect of blood pressure extremes and the exacerbation of brain injury rather than the effect of REBOA itself? And since the hemodynamic effects of REBOA vary based on the degree of hemorrhage and resuscitation in the patient, its effect on TBI may vary as well. We needed a way to control for these confounders, and that's an idea I'll come back to in a little bit. Meanwhile, in Japan, physicians were asking the same question clinically in the application of REBOA. An 87-year-old woman presented with hemodynamic instability after being hit by a car. Initial imaging suggested she had a pelvic fracture and mild brain injury, so REBOA was deployed. She was treated with a zone 1 REBOA and concurrent massive transfusion, such that her blood pressure during occlusion rose from a systolic of 70 to a systolic of 180. She then developed massive intracranial hemorrhage and died from her brain injury. So was this REBOA or over-resuscitation? As the two main causes of death from trauma are traumatic brain injury and non-compressible hemorrhage, is it possible that in some patients we're just shifting the cause of inevitable death? So AJ and Christina are each working on different aspects of epidemiologic analyses that are going to help improve our understanding of patient selection. While Emily, Merrill, Harris, and Andrew, and a few others in the lab are understanding our advancements in REBOA and how to combine REBOA with ongoing resuscitation efforts more safely. There are other potential contraindications that are also hotly debated, but for each there have been cases encountered in which the potential to save a life with REBOA has outweighed the potential risks of not trying it. So at the moment, there are no simple rules that can substitute for sound clinical judgment and an understanding of physiologic principles. In any case, the most important thing to remember is that when balloon inflation begins, the clock starts ticking. The average Zone 1 occlusion time in REBOA survivors is only 20 minutes, with no survivors being reported beyond an hour of continuous occlusion. Strategies to overcome this limitation have been developed, with the two main methods in use known as intermittent and partial REBOA. Intermittent REBOA consists of slow, complete balloon deflation and subsequent reinflation at regular intervals as physiologically tolerated. The use of intermittent REBOA is associated with extending the tolerable duration of supraciliac aortic occlusion from less than an hour to more than 80 minutes. However, this technique has also been criticized for generating oscillating hemodynamic extremes that may have contributed to the death of some patients. Partial REBOA is a technique in which the balloon is partially inflated or deflated as needed to maintain normotension. This allows some degree of continuous blood flow to distal organs and has become the favored technique around the world, as research from our group demonstrated that it can extend the tolerable occlusion time, reduce ischemic metabolites, and reduce the incidence of multisystem organ failure compared to complete occlusion. The specifics on how it's performed vary around the world. However, the UC Davis method of partial REBOA is now the most commonly used method in the United States. It consists of a fine adjustment and coarse adjustment balloon titration syringe attached to a stop clock that will allow incremental adjustment in balloon inflation volume in order to maintain normotension throughout the dynamic process of hemorrhage and resuscitation. It's labor intensive and requires continuous blood pressure monitoring both above and below the level of occlusion. It needs at least one provider dedicated to constantly manipulating the balloon throughout the occlusion period. We've used this technique in trauma patients and in high-risk elective patients as a bridge to balloon deflation. And while we have had technical success, we recognize that there's still much room for improvement. The fidelity of our balloon adjustment was still less than ideal, as you can see from this hemodynamic graph of the patient I just showed. There was much more variation in proximal hemodynamics than we desired. So we went back to the lab and studied the fluid dynamics of the balloon volume adjustments in a flow chamber. This graph depicts the return of distal aortic blood flow as the REBOA balloon is deflated slowly at a rate of 1 milliliter per minute. The balloon approximates the aortic wall until several milliliters of saline are withdrawn. When blood flow begins returning, it comes back suddenly, even exhibiting supernormal flow with less than 1 milliliter of adjustment in balloon inflation volume. This corresponds to a change in shape in balloon conformation. We concluded that we need to improve balloon design. We started with experiments using non-compliant oblong balloons to give us a longer area of approximation along the aorta and an increased resistance to flow with finer control over balloon inflation volume. We found that partial REBOA achieved in this way was able to maintain proximal blood pressure closer to baseline than complete REBOA and avoided the rebound hypotension seen after balloon deflation at 90 minutes. We also found that we were able to provide reliable, low-volume distal blood flow to maintain organ perfusion and avoid a buildup of ischemic metabolites. We tested this model of partial REBOA in an uncontrolled hemorrhage model, in which we amputated 30% of the liver parenchyma in the setting of coagulopathy and hypovolemia to create arteriovenous free bleeding. With no additional resuscitation, 60% of the partial REBOA animals lived beyond the golden hour, which was more than twice as long as the control animals on average, but still not as long as the animals in the complete REBOA group. While these results were encouraging, the ability of partial REBOA to confer any benefits over complete REBOA required further improvements in early hemostasis. So to improve early hemostasis, we needed even better methods of controlling distal aortic blood flow to promote local clot formation and clot stability. Because no endovascular technology existed to achieve our goals, we combined REBOA with an automated extracorporeal flow circuit with the idea that it would automatically regulate aortic blood flow in response to real-time fluctuation in patient hemodynamics. This approach to blood flow control regulation we termed variable aortic control, or VAC. This tested the concept that full-spectrum variable aortic occlusion could be used to achieve initial hemostasis prior to the restoration of systemic circulation and enhance survival beyond what's possible with current technology. We were able to achieve tightly regulated aortic blood flow within the circuit and adjust the proximal to distal blood pressure gradient with high fidelity. This graph of aortic blood flow and pressure gradient over time, the white area represents the occlusion period. Our goal was to achieve a flat line at 300 milliliters per minute of distal blood flow and 65% pressure gradient to produce stable proximal blood pressure and stable distal organ perfusion, which we were able to do reproducibly. We then repeated our experiments in the uncontrolled hemorrhage model and carried out survival for 6 hours during subsequent ICU care. This graph demonstrates survival in the experimental arm, here termed PRH for permissive regional hypoperfusion, shown by the dashed line. It outperformed complete REBOA 2-to-1 in this rapidly fatal model. This achievement caught the interest of Prytime Medical, who worked with our group to create a prototype endovascular device that could incorporate this technology. What we have termed now endovascular variable aortic control, or EVAC, is now being realized in the next generation Prytime partial REBOA catheter that's being tested in animal models at the lab I'll be joining with Dr. Alam and Eliason in Michigan. Circling back to our question about brain injury. To better understand the impact of REBOA on TBI, we needed to minimize variables during the post-intervention phase. To achieve this, we used VAC as a blood pressure support device during ICU care. As you can see on this graph, all three groups, control, partial aortic occlusion, and REBOA, had identical blood pressures that were stably maintained for 6 hours after damage control surgery, despite variable resuscitation needs, levels of myocardial dysfunction, and ischemic burden in the animals. So could this ability to provide reliable, continuous blood pressure support change ICU care? If we can maintain a desired degree of proximal perfusion pressure without compromising distal organ blood flow, despite the presence of multi-system organ dysfunction, can we enhance survival? And this is our current line of research. We may not be far off. While our lab continues to push the boundaries of new technology, we'll circle back to partial REBOA as we're able to achieve it now with existing technology. Despite its flaws, we believe it confers many advantages over complete occlusion, including reducing ischemia and improving the transition to normal circulation. Clinicians around the world have agreed and are starting to adopt the practice of partial balloon occlusion as an adjunct to REBOA. The stars here represent the countries that have published their experience with partial REBOA since we first reported it 3 years ago. Japan is the country with the most experience in REBOA, having performed it broadly for more than 10 years. Initial experience with complete REBOA, achieved with older occlusion balloons more similar to the CODA, led to several instances of devastating consequences and many publications warning that outcomes with REBOA may be worse than no intervention at all. But only 1 year later, since adopting the newer balloons with smaller 7 French sheaths and instituting partial REBOA, outcomes have substantially improved. The latest publication touts that survival has more than doubled what was predicted for severely injured patients treated with REBOA with these adjustments. These achievements have been made possible by REBOA innovators and early adopters who laid the groundwork for this research initiative at David Grant Medical Center and UC Davis. As you may notice, many of the military surgical leaders have moved on to other assignments or civilian positions as their duty has completed. Dr. Neff, Dr. Williams, and Dr. DeBose. This leaves our civilians, Dr. Galante representing surgery, and Dr. Johnson representing emergency medicine at the helm, and they need help. As I look around the audience today, I see experts in aortic physiology, in cardiac support devices, in trauma and critical care, resuscitation, and research of all kinds. I see an entire department of people who have so masterfully handled ischemia reperfusion injury that they routinely bring back organs from the dead. And this is truly a special place. You all have something to contribute, and the continued innovations in patient care that now lie at the interface between disciplines. Whether you're a fan of REBOA or not, REBOA is coming, and UC Davis has the opportunity to lead the way. We can shape practice to ensure patients around the world receive the best possible care. And my challenge to you is to get involved. In summary, REBOA is both a resuscitation and hemorrhage control device with many potential applications that you will see more of. Indications and contraindications to REBOA are evolving, and new technologies and techniques are being developed to improve the safety and efficacy of REBOA. The unique partnership between UC Davis and the Air Force has put us in a position to lead the way. And I want to thank the rest of the team whose tireless efforts made these achievements possible. I'd like to thank them for their endless support of me and my family, even when that meant converting the lab's PACU into a nursery. And thanks to my husband, who plays single dad more than he would like, and who accompanied me to every conference to show his support and to hold our baby when I was on stage, except for that one time when nature called at the same time as Dr. Livingstone. A hashtag trauma mama wins the COT. Little did he know, his bladder would help advance women's equality. And I'd like to thank the department for doing just that, for helping to train the next generation of surgeons and change attitudes about what we should look like. Thanks to UC Davis, if my daughter wants to be a surgeon, she'll have plenty of role models to look up to. And thanks to my fellow residents, who have made sure that there's never a dull moment. And for those medical students out there, when you interview for residency, you aren't just interviewing for a job, you're joining a family. These are the people who will give you the strength to go on when times are hard. And these are the people who will celebrate with you when life brings joy. They may become your spouse, your best friend, or the godparents of your children. So I hope you can join a group as good as this one. It's been a great 7 years. Thank you.
We have thought it was a great 7 years to have you with us as well, and we know that you're going on to do really great things. And I think your challenge is really amazing. And the other thing I realized is that this whole REBOA thing essentially happened in your lifetime here. It's a pretty amazing opportunity to be part of a whole new adventure in medicine that started out for one indication, but all the other ways that people are thinking about it is really extraordinary. Excellent, really excellent review. I think we've got time for questions, and I know there are people with lots of thoughts. Dr. Galante, take it away.
That was an excellent talk. I just want to point out that Dr. Russo was quite modest in the papers that she chose to quote during her talk. So having just looked at the 80 REBOA papers that are in the literature right now, Dr. Russo is author or lead author on over 25% of those papers. So really the advancement for REBOA in the clinical side, like we know, is all based on the translational work, which Dr. Russo really was the driving force with her colleagues at David Grant to be able to do. And while it's an outstanding talk, I do recognize your modesty in that talk. So thank you.
Great talk. An important aspect of organ preservation / survival with aortic occlusion of almost any kind is temperature control. Do you have any data about that?
We haven't had any data coming from our translational research, and clinical research is still too juvenile to really produce reliable data on smaller details like temperature control. But what I have noticed in the lab is that during occlusion, the esophageal temperature probe and the rectal temperature probe would read two completely different numbers, because distal stasis would create increased thermal burden on the patient below the level of occlusion because of the temperature blankets and the warming pads that are placed under them. So I think that if we are going into a realm where we're going to be working on patients with potentially longer durations of surgery that require intermittent periods of occlusion, it's something to consider with the differential temperature management.
I enjoyed your talk. Someone sort of coming from the outside, comment and question. So, we've experienced a lot of new technology, and there's a very sort of typical trajectory of how new technology is used. There's sort of a start, and then a lot of interest, and then there's sort of all the complications, then sort of the use falls down, and then at some point it sort of stabilizes at some point once all of this work is kind of sorted out. And so it's great that you're doing this. For someone from the outside, there's a number of concerns, questions about the research. A lot of the research is being done by people who have an interest in both and expertise in both general and vascular surgery. DeVos and Eliason, Rasmussen, they're all trauma surgeons and vascular surgeons. I think Eliason is mostly vascular. My question is, with the training programs that you've had, if you had an opportunity to really investigate how successful those were, because from a clinical and practical perspective, concerns that people have are delays in care because there's a delay in putting the REBOA in, or complications because it's either put in incorrectly, inflated incorrectly, or that there's some sort of injury, added injury with our technique. Just curious if you've had a chance to go back to some of these physicians who have been taught how to do this to evaluate how effective the program is.
So with specific regards to the training program here, I think that's still in evolution. But if we look kind of more broadly at the global perspective, in Japan, most of their experience with REBOA developed because they don't have many in-house surgeons. So almost all of their REBOAs are placed by emergency room physicians. They've adapted practice into their training to teach REBOA to all people who are going into emergency medicine as part of their standard to graduate from ER residency. And that includes shadowing with vascular surgery or interventional radiology in order to be deemed equipped to safely provide ultrasound-guided access to the common femoral artery and do cut down if they need to. So I think adapting some of those models into our training process can provide us some directions on where to go in the future.
We'll start out. We won't stay second one. First we'll go Dr. Nye and then Dr. Russo.
Rachel, really nice summary and overview of kind of this REBOA story. Touched a little bit about pediatrics, but I wanted you to expand a little bit on that. Can you talk a little bit about our experience here at UC Davis with adolescents or pediatric populations, and what adjustments need to be made when REBOA is used for smaller and younger patients?
So most of what we have captured here has been in adolescents that are 16 to 18, and in those patients they were more body types that were similar to adults. And the publication that I had cited was the first clinical publication that looks at youth, which was similar, those who were under 18 in the literature, mostly coming out of the experience in Japan. And those patients also were more adult-sized. What we're looking into here is trying to see if we can measure what types of balloons would be used for pediatric populations. So some of the work that Eric and some of the others were looking at in the lab from a physiologic standpoint was using the pig model with the younger pigs as sort of a surrogate for the physiology of a child. And then what Dr. Trappe was looking at was using Fogarty balloons for smaller sized aortas that are 12 millimeters or less to see what we could substitute for REBOA out of existing technology that might be available in level 1 trauma centers now.
So kudos and a challenge for you. Congratulations for really taking on a topic and in an iterative, hypothesis-driven fashion, really trying to figure out how to solve different nuances of the problem and advance the topic. The challenge is, as you're probably well aware, in our field in particular, in emergency care generally, there are numerous examples where we adopt something because we need a solution for a problem, well before there's really very high quality evidence supporting its practice. So, what are your thoughts on truly advancing the on this particular topic?
So I think that's going to be very important, and the steps that the AAST was making with the aorta trial is going to be key to trying to look at our own practice as it evolves across the country. What we can see is the experience in Japan and how it has changed over time. Since our efforts with the first publication from the aorta trial had 46 patients compared to the 460 in the first Japanese paper. So when we look there and we look at the growing adoption of REBOA in practice in China, they have access to a patient population that's much greater than ours, and I think we'll rapidly be able to get the kind of numbers that we need to see for some outcomes. Right now, it's difficult to say, even with prospectively collecting data, it's all analyzed retrospectively, and the patient population is sick with lots of confounding variables, and there's no real good information out there yet about how to combine REBOA when you have access to blood or you have access to resuscitative fluids. When the initial idea was developed in a military austere setting where you did not have access to those things. So I think those are some of the keys that we're going to have to sort out, and incorporating those longitudinal models of data capture with broader adoption of the aorta trial, I think is going to be key to that.
Hi, so jumping topics a little bit, as Dr. Gladue mentioned, you had a phenomenally productive 2 years of research time, and I was wondering if you could speak to some of the younger residents as to how to set themselves up for success if they're preparing in a research year, thinking about what you might want to be doing. Is there anything that you'd like to share with the younger residents?
Great question.
Yeah. The advice that was given to me was actually super corny, but really good. I ran into Dr. Neff after a grand rounds, and he said, "You know what? My best advice to you is to hitch your wagon to a rising star." What the heck does that mean? But I mean, he was right. He said, look around, see what people are doing, figure out what research interests you, and if it seems like somebody has an idea that is both interesting and they've got the enthusiasm behind it to try to push their work forward, that's a good lab to join. And I did, and I'm really glad that I did.
Really enjoyed your talk, Rachel. Just have a comment, a question and a comment. Are you aware of REBOA being used at all in organ donation in the setting of donation after circulatory death? Because the reason I ask is about 15 years ago, there was a series of cases that came out of Michigan where it was in VCD donors where the patient expired. They put in a Foley catheter into the thoracic aorta to include it, and they put the abdominal component, the abdominal organ of the patient, on ECMO. So they circulated the organs in a normal fashion. It's called regional normothermia. And then they procured those organs in a setting that was somewhat like this. So they had a normal perfusion of the liver, pancreas, and kidneys, and they did a series of transplants where those organs all did very well. And so it seems like a great application of REBOA in the setting of organ donation, which could be studied in the lab, or could be easily implemented in a place like UC Davis. So have you seen, you're going to Michigan, that's where they did this regional normothermia. As an anecdote, all that research was led by former transplant surgeons from UC Davis who went to Michigan. But just maybe something to think about, and something we could talk about implementing here in conjunction with RPO.
Well, I think that's an amazing idea, and bringing it kind of full circle, there's been a lot of interest in combining REBOA with ECMO, and going on to study REBOA as a resuscitation device with the application of the VAC automated catheter could add a whole new level to what we're able to accomplish. So it would be really cool to kind of bring that all full circle.
Sounds like a collaboration worth maintaining and thinking about, again, because of our unique OPO. Dr. Lee and then Dr. Elise.
So from a device standpoint, I was very interested in the fact that you sort of look at those pressure gradients, proximal and distal to balloon included. And it kind of struck me that I think proximally, there's a lot of information about cerebral perfusion pressure with intra-aortic balloon pumps. There's all this information about coronary flowing and so forth. But it seems like what you're looking for distal to the balloon is really flow, right? Not necessarily pressure. And pressure you're using as a surrogate to identify what the distal flow was in towards the. And as I thought about it, I was thinking about intravascular ultrasound. So intravascular ultrasound currently exists and is used pretty widely. Does that have Doppler flow? And could you use Doppler distal to the balloon to get flow and fine tune? Because maybe what's happening is that in some of these situations, both clinically and in the research lab, is that pressure readings distal may not necessarily be good enough to fine-tune flow. And if you could use Doppler, maybe you could get flow. Has anyone thought of that? Or?
Yeah, you have hit on a very important thing that we had come across in our studies at David Grant. There is a dissociation between pressure and flow, particularly as you have progressive hemorrhage and at the lower volumes of blood flow. And measuring blood pressure is much easier to do than measuring blood flow. We tried a variety of external flow probes that require actually you have to cut down onto the artery, place it around the artery circumferentially, make sure that it doesn't move, use some transonic gel. And trying to get that built into an inline flow probe device is one of the key features that we're working on with the newer technological advancements for the next catheter. Found that flow is a much better measurement than blood pressure for all the things we're trying to do.
I don't know about my partners, but we have a lot of experience putting these catheters sort of semi-blindly, with wires, like the venous cannulas when we do peripheral bypass and also arterial access. But I always get very anxious because the vascular side of me says I need imaging. How am I putting this wire up there blindly? And we're not really blindly because we have TEE to be able to make sure that our wire is actually in the right atrium, wherever it needs to be, or in the descending aorta. How do you guys do it? I mean, I almost poop my pants every time I put it up there blindly without imaging.
That's the cardiac side.
No, that's the lab. I mean, in my brain, I have Dr. Pevick yelling at me because I don't have imaging.
Yeah, everybody
wire
does
is
that.
So how do you guys do it? I mean, I was approached by the OHSU trauma group it was Susan Rao, I believe, to teach them how to put these wires up there without imaging, because that's what you do, right? You don't have any kind of imaging when you're putting those wires up there. How do you know the wire isn't going down the other iliac or into the renal or SMA or any of those things?
So there's a few different answers to your question, which is a very good question that is encountered all the time as people start to adopt REBOA across the country. Looking at the previous experience with CODA, most of the complications with malpositioning came from not having good image guidance available at the time when they were placing those long wires and catheters. With the newer REBOA catheter, that there is no wire, it's all nitinol stiffened catheter. It's much more resistant to migration, but it is not entirely free of migration. When placing it blindly, which is described based on landmarks, it's external measurements using the body landmarks with the catheter markings in order to determine how far to advance it. There have been some people who have described using the balloon markings on the x-ray as a way of trying to figure out kind of if you're in the right spot or not, and if it's taken the correct trajectory. That can be done fairly quickly in the emergency department before or after the balloon's inflated. Some centers even have a little bit of mixed contrast that they keep in with the REBOA kit so they can inflate the balloon with contrast and see exactly where it is. It's a little easier if you're looking at one of those bedside monitors that are not very good down in the ED to determine where an inflated balloon is with contrast as opposed to a just those small markings on the catheter.
And the new catheter, which we do use, is more a picture like a pigtail catheter. So it's got that very curled end on it, so that you can push it up. And a lot of us will push a pigtail sometimes without a wire in it when we're doing vascular cases. So it's a lot more gentle than what it used to be when we were using the Coda. I'll put it in there for you.
I was gonna suggest if you're using, I mean, one way to do it is just put an IVUS up there, IVUS catheter, get your wire up there, and you know exactly where you're at, and you know, and then you don't need imaging, basically. That's your imaging.
Yeah. The ER docs are not as familiar with using the IVUS.
Dr. Chapman.
Enjoyed your talk a lot. I have to disclose a pro-renal bias, obviously, with my question. Looking at these embryonic expansions into the areas of managing blood flow in critically ill patients, MSOF, or doing prophylactic and high-risk procedures, are people routinely, in those cases, for instance, insufflating balloon below the renals? Balloon, acute kidney injury is a big driver of peri-procedural, peri-traumatic mortality, and so what you gain with REBOA may be losing by having a lot of patients with kidney failure there after the intervention. So, for instance, that case report with the patient who refused blood pericardium, did you insufflate the balloon below the renals or above the renals? And what's the general approach in the REBOA for renals with this kind of more chronic indication question?
For those cases in which they're going to be isolated to pelvic trauma or pelvic operations, and it's fairly routine to keep the catheter below the renals. For our case with the woman with invasive placenta, there was concern that she may have some collaterals that were coming off of the mesenteries, which are a bit unusual. So for her, we had supraceliac occlusion for about 10 minutes. Then we moved in for renal after they were able to address some of the early hemorrhage and get some better hemorrhage control with exposure.
Do you want to just give a little more detail about that particular case? How that you organize that multidisciplinary team? Because I think that's another sort of tour de force in making things happen. And when people, you know, get cynical about, you know, UC Davis and all the things that drive us nuts on a day-to-day basis, that was an extraordinary, amazing thing that happened here.
Yeah, well, I think I got to give the shout out to Dr. Leshikar on that one. For that, there was, I think the initial idea came from one of the OBGYN onc fellows who had rotated briefly through the SICU for like 2 weeks, saw him talk about REBOA, thought about the idea, and when this case came up, suggested, well, why don't we call the trauma team and ask them if REBOA could help? And the two of us were on call that day and came over and started talking to them about it, and there was a little bit of serendipity that we happened to be on call and know about REBOA in such detail. We were able to answer all of their questions, and from there, we made efforts to bring more people in. Dr. Humphreys came onto our team, and we were able to set 22 providers all together at one day to achieve that accomplishment. So it was pretty impressive.
And it's amazing work. I'll just want to speak a teeny bit to your comment, Dr. Mellon and Garth. Although it's not exactly parallel, but it was probably 20 years since the adoption of fetal surgery was just being done everywhere around the world, and before the first randomized controlled trial sort of asked the question. And I think vascular has a history of some of the things getting adopted, and then you learn by asking specific questions later on. So I think you're looking at a 20-year career based on maybe go faster because there's the incidence is greater, I think, for use, but the indications are also broad. But I think you can go a long way with this and learning a lot about it and making an enormous contribution to our field, and that is really a great privilege. So thank you for sharing your journey and being so open to thinking about new ways to help people. Take care, and really love you.